So today's my name is Dr. Prasad. I'm doing my IDCCM here at LITHIUM Global. So today's our topic of discussion will be approach to the common toxidromes. Yes, as said, these are some most common common thing that we see in our emergency department and in critical care units. But the only backlog is we don't have enough data or guidelines on the toxidromic approach. And that makes the situation of a clinical assessment or managing the patient very complex. So it is a very complex scenario to diagnose and manage a patient who comes with toxidromic to presentation with the toxidromic presentation. So today our aim is to how to systematically approach in a stepwise manner so that we can easily assess and manage the patient who presents in a toxidromic state. So it is a constellation of symptoms caused by dangerous levels of a particular group of toxins in the body, and it is most often due to the drug overdose. And today in this discussion, we will also be focusing more on common drug overdoses and also common syndromic approach. Just a case scenario, I have made up this case scenario. A 36-year-old male, a known case of depression disorder on antidepressants, was brought to the emergency with a history of a seizure episodes 15 minutes ago. On arrival to ER, he was drowsy, opening eyes and responding to deep painful stimulus, not localizing to pain. His BP was around 80/50, heart rate around 145, and a 12-lead ECG done was showing a QRS of 0.12 seconds. So this is the case he presented in this presentation. What will be your next immediate approach? How will you diagnose and how will you manage is what we are going to learn in the next coming few minutes. The initial approach always A, B, C. All of you might be aware of it. Airway, we have to make sure on presentation the patient's airway is patent and his breathing mechanics are all right and he is hemodynamically stable. So when coming to airway, if at all he is not maintaining his or he is not protecting his airway or airway is not patent, go for a rapid sequent intubation if necessary or indicated to maintain airway patency. However, prior to giving sedation and muscle relaxants, urine for toxicology screening must be conducted. In any patient presented with altered mental status or in a non-specific symptoms, if you are suspecting a toxidromic or any drug overdose consumption, always collect the urine toxicology for screening prior to giving sedation to the patient for intubation. And coming to breathing, the patient's oxygen status can be monitored with a bedside pulse oximeter. Give oxygen by the nasal cannula or face mask to maintain SpO2 more than 95%. When the patient is in respiratory distress and is unable to maintain oxygenation or ventilation, assisted ventilation should be considered, be it non-invasive or invasive, based on the patient's clinical condition. In circulation, monitor pulse and blood pressure, do an ECG, obtain large bore IV cannulas to start IV resuscitation with IV fluids if not contraindicated, and vasopressors if continues to be hemodynamically unstable, preferably norepinephrine. Coming to history and physical examination, most of the times your history, detailed and thorough history, targeted history from the family or friends, whoever were the bystanders who brought the patient to you, will give you the diagnosis most of the time. They can give you a history of over-the-counter medications, be it you can do a pill count of the empty strips available. So the robust history collection and physical examination will give you the clinical diagnosis initially on presentation itself. So the detailed and targeted history from family and friends is necessary. The history should include the type of toxins or toxins, time of exposure, and route of administration. Whether it was an IV drug abuse or he has taken orally tablets or subcutaneous or intramuscular, anything. So coming to physical examination, your physical examination should be more robust and focused towards the neurological findings or maybe the many anticholinergic symptoms like dry mucous membrane or maybe constipation or vomiting. So these things must be focusedly assessed for. So CNS examination, as you all know, GCS and AVPU are two common scales: alert, verbal, painful, and responsive scales. These two are the easy scales to assess the neurological status of the patient. Then next, you can what is find is pupillary findings, whether he's having mydriasis or meiosis. That will also give you help to give diagnosis most of the time, whether it is any opioid induced opioid overdose, whether the patient was already on any opioid analgesics or was having any underlying patches. So these pupillary findings with meiosis will give you a definite indication towards the toxidrome. So movement disorders like seizures are also important. Skin findings like flushed or pale, dry or warm, like in anticholinergic overdoses, you can find a dry skins and flushed skin. And temperature alterations like hypo or hyperthermia are important, and respiratory alterations. Again, opioid overdose or anticholinergic overdoses, you might find respiratory depression leading to respiratory acidosis. So respiratory alteration is also has to be examined thoroughly. What are the clinical features that you can find in drug overdoses or any poisonings? The toxic overdose can present with a wide array of symptoms like abdominal pain, vomiting, constipation, dry mucous membranes, tremor, altered mental status, seizures, cardiac dysrhythmias, and respiratory depression. So someone presenting to your emergency with any of the or all of the features, above given features, with unexplained background pathophysiology, you should always suspect for the drug overdose or poisonings. Coming to the investigations, what all the investigations you would like to get is routine blood investigations like CBP, electrolytes, blood urea nitrogen, blood glucose and bicarbonate levels, your LFTs, liver function test, coagulation profile, arterial blood gas analysis, ECG, and also sample for urine toxicology screening. So these are the investigations that you would like to get it done, and based on the abnormalities, again, for example, with the normal anion gap metabolic acidosis, you have a wide array of drugs causing normal anion gap metabolic acidosis, and high anion gap metabolic acidosis. There are a few drugs like tricyclic antidepressants. These all cause you the high anion gap metabolic acidosis. So based on that also you can classify. So now, which patients require close monitoring or ICU admission? Means what are the prerequisites for the ICU admission or close monitoring? Someone with a respiratory depression, that is a PaCO2 of more than 45, someone with ongoing or history of seizures, someone with cardiac arrhythmias with prolonged QT interval and preferably corrected QTC, and also prolonged QRS, that is more than 0.1 seconds, second or third degree AV block, systolic blood pressure of less than 80 mmHg, unresponsiveness to verbal stimuli, a GCS of less than 12. So these are the features or clinical signs when preferably the patient will require close monitoring or ICU admissions. And the other prerequisites for ICU admission or close monitoring is someone requiring emergency dialysis for enhanced elimination of the toxin that which they have consumed, provided it is dialysable, and hemoperfusion or extracorporeal membrane oxygenation. Someone with increased metabolic acidosis, and also tricyclic or phenothiazone overdose manifesting anticholinergic signs, neurological abnormalities, QRS duration more than 0.12 seconds or a QT of more than 0.5 seconds. And someone requiring continuous infusion of naloxone, that is suspecting or diagnosed opioid overdose, and you are planning to start an infusion of naloxone, preferably he should be given with a close monitoring in an ICU setting. So to brief up again, how will you manage, again coming back, initial assessment with the parallel stabilization of the patient like A, B, C. Once the patient is more stabilized, then come to the decontamination. We'll discuss a little bit about decontamination in the next slides. Enhance elimination, other basic supportive measures, and antidotes. We'll be discussing these in the coming few slides. For decontamination, the patient should be thoroughly undressed. The clothing should be removed in suspected or confirmed dermal exposures, and skin should be copiously irrigated and washed with a mild soap. So for example, someone presented to your emergency department or ICU with an alleged OP poisoning consumption, you will have a clear odor, and the risk of dermal exposure is also very high and can cross-contaminate staff also. So priority will be he should be thoroughly undressed and check for all dermal exposures, and the skin should be copiously irrigated and washed with a mild soap. And coming to gastric lavage, place of gastric lavage in acute poisoning is yet debatable and is only of benefit in the hyperacute phase of poisoning, that is less than 1 hour. The gastric lavage is still, there are two schools of thought and it is debatable, but however, within 1 hour of consumption of the poisoning, it is recommended to do it. But you should make a note that the patients must be aware with a preserved gag reflex that his airway should be protected to do a gastric lavage. Then coming to charcoal administration, charcoal aspiration has a high morbidity and mortality and should not be attempted in patients without a safe or protected airway. Charcoal administration is most effective when it given within 1 hour of ingestion. However, there are a few contraindications for charcoal administration, which are elemental metals like lithium or iron, like lithium toxicity or iron overdose. Better to avoid the charcoal administration. In pesticides, overdose of strong acids or alkalis, cyanide poisonings, and also late presentations of more than 4 to 6 hours post ingestion, better to avoid charcoal administration. For decontamination, so these are some few common antidotes that I have given in the table. In this, namely, I would like to mention about acetaminophen. N-acetylcysteine can be used as an antidote, and more other common can be beta blockers. You can use glucagon for treatment of beta blockers overdose. Calcium channel blockers, you can use calcium gluconate and glucagon for treatment of the calcium channel blocker overdoses. And again, for opioids overdose, naloxone can be used, and tricyclic antidepressant sodium bicarbonate can be used for treating tricyclic antidepressant overdoses. The use of flumazenil should be contraindicated in many situations, including tricyclic overdose or in chronically habituated benzodiazepine user, as this may precipitate seizures. Now, again, I'll come back to the same question. A 36-year-old male, known case of depression disorder on antidepressants, was brought to the emergency with a history of a seizure episode 15 minutes ago. On arrival to ER, he was drowsy, opening eyes, and responding to deep painful stimuli and not localizing to pain. His BP was 80/50, heart rate around 145, and with a QRS of 0.12 seconds on 12-lead ECG. So I have given you the initial stepwise approach. So what will be your next immediate approach? So I will just brief it up again to you. As I said, A, B, C, airway, breathing, circulation. In the given case scenario or case with Nete, we can see that his sensorium is not appropriate and unlikely that he will protect the airway. So better to protect his airway first. And again, prior to sedation the patient or paralyzing the patient, better to collect urine for toxicology screening. And breathing, maintain adequate oxygenation, and also circulation. His blood pressures are on lower side, that's 80/50. So again, you secure 2 large bore IV cannulas, give appropriate fluid resuscitation, and if at all, despite adequate fluid resuscitation, continues to be hemodynamic instability, he continues to be unstable, then go for vasopressor support, preferably norepinephrine is the drug of choice. So that will be our next immediate approach. And diagnostic approach, again, investigations, all routines. And again, there are no specific diagnostic approaches for the toxidromes, be it drug levels, they're all non-specific. But again, I will discuss a few common toxidromes. In that, drug-wise, we will discuss the following: diagnostic approach and management. One of the few common toxidromes is tricyclic antidepressant overdose. They are widely used to treat depression, also used to treat migraine, neuralgia, and nocturnal enuresis in children. A first case of tricyclic antidepressant overdose was reported in 1959. The commonest fatal drug overdose, second only to the analgesics. Fatal and most commonly seen tricyclic antidepressant overdose is amitriptyline. What are the toxicokinetics and pathophysiologies of tricyclic antidepressants? That is, the overdose causes altered pharmacokinetics and delayed absorption due to the anticholinergic action of tricyclic antidepressants on GIT. So, as it has a lot of anticholinergic action on GIT, since it will cause sluggish movement of the bowels, leading to constipation, and also this will result in delayed absorption of the drug overdose that they have consumed. And inhibition of norepinephrine reuptake at neroterminals, causing hypotension, direct alpha adrenergic receptor blockade. They have a pyridine-like action on the myocardium, leading to prolongation of the QRS. Again, acidosis reduces the protein binding, leading to increase in unbound tricyclic antidepressant in the plasma. Usually, tricyclic antidepressants are lipophilic and highly protein bound. So, whenever there is an acidosis, this is metabolic acidosis will reduce your protein binding of tricyclic antidepressants, leading in free drug levels of tricyclic antidepressants, and that will further worsen your toxicity. So that is why correction of acidosis in this is very important. Now, clinical features. What are the features that you see? Predominantly, we see the clinical manifestation can be classified as anticholinergic, cardiovascular, and CNS. What are the anticholinergic effects that you see is reduced GIT motility causing IDS. Occasionally may cause toxic megacolon or intestinal perforation, mydriasis and blurred vision, dry skin and mucous membranes. Mucous membrane and skin are very dry in anticholinergic overdoses. You can see mydriasis and blood vision in all anticholinergic overdoses, and also, as I said, ileus, megacolon or intestinal perforation are also common finding in these, and which will lead to further delayed absorption of the drug overdose. What are the cardiovascular effects that you see is sinus tachycardia with prolonged QRS, QTC and PR intervals. Prolonged QRS on ECG is a good bedside tool for diagnosing and predicting the severity of tricyclic antidepressant overdose. Like if QRS is more than 0.1 seconds, it has shown to predict seizures, while QRS of more than 0.16 seconds is associated with both seizures and ventricular arrhythmias. Therefore, is a very poor prognostic predictor. It's a predictor of very poor prognosis. And also hypotension because of direct alpha adrenergic receptor blockade and vasodilatation. And the other cause of hypotension is decrease in myocardial contractility due to the inhibition of sodium influx. What are the CNS effects that you can see in this? Lethargy, drowsiness, delirium, seizures, respiratory depression, and coma. Patients presenting with seizures, coma are found to have very poor and fatal outcomes. Acidosis caused by seizures in turn reduces the protein binding of TCA, thereby increasing the drug toxicity that we have already discussed. So please remember these clinical features of anticholinergic overdoses. So mainly the main symptoms to look out for in anticholinergic are the sensorium, altered mental status, whether he is in a depression or comatose or stupor or he is having seizures. Then dry skin and mucous membranes are one strong clinical feature. Then you reduced GI motility leading to ileus, toxic megacolon, or even a perforation is another strong clinical feature which indicates strongly towards the diagnosis of anticholinergic drugs overdose. For lab investigations, what all you have to notice is tricyclic levels of more than 1000 nanogram per ml is significant, but the level of tricyclic levels correlate poorly with toxicity, which means a higher level of tricyclic levels will not indicate or have a poor implication on the toxicity of the drug. And prolonged QRS with more than 0.16 seconds can be used as a predictor of seizures and ventricular arrhythmias. Respiratory acidosis due to respiratory depression, and metabolic acidosis due to hypoperfusion and also seizures. Now, treatment again, as we have discussed in the general approach, initial stabilization with A, B, C, then decontamination, gastric lavage followed by activated charcoal within 1 hour of ingestion is the preferred method of gastric decontamination. However, multi-dose activated charcoal, particularly in the presence of reduced GI motility, is not recommended. And then again, enhanced elimination. So how by alkalinization, it remains to be the main step of therapy for anticholinergic overdose, especially TCA. Sodium bicarbonate increases the protein binding of the drug, thereby decreasing the unbound drug in the plasma and decreasing the drug toxicity. Sodium bicarbonate should be continued until the QRS narrowing is achieved, that is, it is less than 0.1 and 1 or the pH is more than 7.5. So these will be our goal of our target to achieve. Until then, we have to continue our soda bicarb infusion or administration. Hyperventilation is also an alternate strategy in intubated patients. However, we should be cautious of mixed alkalosis as it is associated with higher rates of mortality. Now, as we have discussed in the cardiovascular effects, that there are many arrhythmias, TCA overdoses are associated with many arrhythmias. So, general correction of hypoxia, hypotension, and acidosis itself reduces the cardiotoxic effects of the tricyclic overdoses. And however, if required, antiarrhythmic agents are better avoided as they prolong the depolarization and further cause QTC prolongation. So class 1A, 1C, and 3 antiarrhythmic agents are not recommended or better avoided in anticholinergic overdoses. Lidocaine is effective in treatment of refractory ventricular arrhythmias. TPI may be required in high-grade blocks. Hypotension, most of the times it is refractory to fluids and will need vasopressor supports, ideally norepinephrine. So, coming to the conclusion or take-home message, always assess and manage ABC, airway, breathing, circulation as necessary. Look for the clinical features, anticholinergic, CNS, and cardiovascular. Anticholinergic, as I've said, dry mucous membranes, altered mental status, constipation, that is reduced GI motility. These are the main features. CNS, cardiovascular. Okay. And QRS prolongation to be used as a bedside tool to assess the severity of toxicity and clinical outcomes. Gastric lavage followed by activated charcoal within 1 hour of ingestion. Multi-dose activated charcoal, particularly in the presence of reduced GI motility, is not recommended. Sodium bicarbonate remains the mainstay of treatment. And avoid antiarrhythmic agents like class 1A, 1C, and 3. Lidocaine may be used for refractory ventricular arrhythmias. Norepinephrine for hypotension. Manage seizures with benzodiazepine, phenytoin for refractory seizures. So a small question after, as we have also summarized the anticholinergic effects, a small question on TCA overdose. What is the preferred method of decontamination in TCA overdose? A. Gastric lavage with activated charcoal after 4 to 6 hours of ingestion. Gastric lavage with activated charcoal within 1 hour of ingestion. Multi-dose activated charcoal is recommended, or none of the above.
You can answer in the chat box.
Okay, as I'm not finding any answers, so I'll be moving on to the next common toxidrome. That is the opioid overdose. 3 key features to understanding of opioid toxicity. However, I would like to answer this. The main answer to this question will be the gastric lavage with activated charcoal within 1 hour of ingestion. Because the gastric lavage with activated charcoal after 4-6 hours is not indicated, and multi-dose activated charcoal is also not recommended in TC. So, opioid overdose. 3 key features to understand the opioid toxicity is the opioid overdose can have life-threatening toxic effects in multiple organ systems. Normal pharmacokinetic properties are often disrupted during an overdose and can prolong intoxication dramatically. The duration of action varies among opioid formulations, and failure to recognize such variations can lead to inappropriate treatment decisions, sometimes with lethal results. What are the kinetics? GA absorption might be delayed in the presence of aperistalsis due to opioid overdose. Again, in opioid overdose, you have reduced GIT motility. So your drug absorption is, we have a very delayed drug absorption. And it is lipophilic, therefore has large volume of distribution, metabolized in liver. Metabolites are also excreted from urine, have prolonged half-life. Now the clinical manifestation in this, in opioid overdose, the main clinical features I would like you to remember is the classic there is a triad, that is apnea, stupor, and meiosis suggests the diagnosis of opioid toxicity. And however, there are other clinical manifestations like respiratory depression, absent or sluggish bowel sounds, hypothermia, hypoxia, rhabdomyolysis, compartment syndrome, and seizure. So just a small picture of the clinical findings. Whatever I have told you, respiratory depression, meiosis, stupor. However, only apnea, stupor, and meiosis are the classic triad which strongly indicate with appropriate history, whether the patient is having any fentanyl patches or whether he was prescribed of any opioid analgesics for pain management. Along with this clinical triad of manifestations, will give you the diagnosis most of the time. Diagnosis usually is on clinical grounds. There is a triad, that is apnea, stupor, meiosis, such as opioid toxicity. Drug concentrations are not reliable. Opioid exposure is confirmed by urine toxicology screening. However, certain opioids such as fentanyl are not detected by routine urine toxicology screening. Again, ABC, airway, breathing, circulation. Gastric decontamination by gastric lavage may be extended to several hours post ingestion due to delayed absorption. So initially, in my common approach, I have given that gastric lavage is preferably done within 1 hour of consumption, that is in a hyperactive phase of poisoning. But in opioids, we can have a delayed gastric lavage also because of the reduced GIT motility and delayed drug absorption. Activated charcoal should be followed after lavage. However, charcoal-induced obstruction has been described. No role of forced diuresis and hemodialysis. As it is not a dialysable drug, no role of hemodialysis in elimination of the drug. So the antidote that we can use in opioid overdose is naloxone. This antidote of opioid overdose is a competitive mu opioid receptor antagonist. Onset of action usually less than 2 minutes when administered intravenously, and its apparent duration of action is 20 to 90 minutes. However, you should be very careful while administering naloxone, as it can cause sudden withdrawal of opioid withdrawals, and the patient can become very agitated or even may have seizure episodes. So it is administered IV at an initial dose of 0.2 to 0.4 mg. If no clinical response, after 2 to 3 minutes, an additional 1 to 2 mg of IV may be administered and is repeated to a total dose of up to 15 mg. A continuous naloxone infusion may be used 0.4 to 0.8 mg per hour until the patient has a normal mental status and normal breathing. A triad of stupor, meiosis, and respiratory depression suggests opioid overdose. Again, ABC approach, gastric lavage, naloxone to be given with the diagnosis on clinical grounds. No role of forced diuresis or hemodialysis. Let's have a small question. What are the triad of clinical features which suggests the diagnosis of opioid overdose? Is it constipation, dry mucous membrane, or seizure? Is it respiratory depression, hypothermia, or hypoxia? Is it apnea, stupor, or meiosis, or none? So the answer is C, apnea, stupor, meiosis. These are the classical triads with proper history and these clinical features. You can come to a conclusion of opioid overdose. Next, coming to the lithium toxicity. It is a monovalent cation similar to sodium. Its clinical use was first established in 1970s for treating mania and bipolar disorder. It is established as a standard antimanic and mood stabilizing drug, has a narrow therapeutic index. For toxicokinetics, lithium toxicity occurs due to either excessive intake or impaired excretion. Serum lithium levels reflect only extracellular concentration. Therefore, they poorly correlate with the symptoms in acute ingestion. In acute or chronic ingestion, drug concentration level closely correlate with the symptoms. Hypovolemia and hyponatremia leads to increase in lithium concentrations due to increased reabsorption in kidneys. Now, the pathophysiology behind this is, if you remember the periodic table, the lithium and sodium are just pure lithium is sodium. So, our kidneys naturally they consider lithium as sodium. So, whenever there is hyponatremia, they tend to reabsorb this lithium into the bloodstream again, leading to further lithium toxicity. So that is what mean by impaired excretion. In hyponatremia, there is impaired excretion of lithium, leading to lithium toxicity. Now, these are the toxic levels. At what toxic levels, what symptoms you might notice. In a mildly toxic, that is between 1.5 to 2.5 milliequivalents per liter, you can see tremor, ataxia, nystagmus, choreoathetosis, and photophobia, lethargy. In moderate toxic levels, agitation, vascular twitching, confusion, nausea, vomiting, diarrhea, and cerebellar dysfunction might be seen. And in severely toxic patients, the features you see are coma, seizures, sinus bradycardia, that is prolonged QTC interval, and also hypotension. The diagnostic evaluation, how do you diagnose it? With an ECG, you find the QTC prolongation. Leukocytosis is a common finding for almost all toxidromes. Decrease in anion gap of less than 6 milliequivalent per liter. Lithium concentration levels can be used to correlate with the severity of toxicity in acute or chronic ingestions and are to be done after 6 hours of ingestion. Elevated TSH levels are also seen in lithium toxicity. Treatment with adequate therapy, morbidity and mortality is low. Initial stabilization, ABC approach. Gastric lavage is preferred method of gastric decontamination. Activated charcoal is not recommended unless there is a co-ingestion along with lithium toxicity. Enhanced elimination with saline solution or forced alkaline diuresis is not recommended. Refractory shock usually needs vasopressor supports, preferably norepinephrine, and it is dialysable. So elimination can be done by hemodialysis. But what are the indications for dialysis in lithium toxicity? In acute ingestion, the level should be more than 3.5 milliequivalent per liter, or in chronic ingestion, the level should be more than 2.5 milliequivalent per liter, and symptomatic with renal insufficiency. These are the indications for dialysis in lithium toxicity. Seizures again can be controlled by benzodiazepines, and phenytoin can be used for refractory seizures. What is the take-home message for lithium toxicity? It has varied presentation with mild, moderate, and severe toxicity. Hypovolemia and hyponatremia increase the lithium reabsorption at kidney level. I have explained you the pathophysiology behind this. ABC, airway breathing circulation approach. Gastric lavage, avoid activated charcoal if no history of any co-ingestion. Lithium levels of more than 3.5 milliequivalents is considered severely toxic and with renal impairment needs dialysis for drug elimination. Seizure control with benzodiazepines or phenytoin for refractory seizures, norepinephrine for refractory hypotension. Now again, what is the preferred method of decontamination in lithium toxicity? So obviously, as I said, gastric lavage with activated charcoal is not recommended in lithium toxicity if no history of any co-ingestion. So gastric lavage alone within 1 hour will be the ideal answer, because again lavage after 4 to 6 hours of ingestion has no role. So gastric lavage within 1 hour is the answer. Coming to the beta blocker overdoses, you might all be familiar with beta blocker drugs, mainly used in the treatment of hypertension, tachycardias, or chronic heart failures. They provide morbidity and mortality benefit to patients with ischemic heart disease. Other uses seen in anxiety, migraine, headache, glaucoma, and also hyperthyroidism. Toxicokinetics, if you come to toxicokinetics and pathophysiology, peak absorption of beta blockers are achieved within 1 to 4 hours. Absorption might be delayed when co-ingested with drugs causing reduced GI motility. Lipophilic beta blockers like propranolol easily cross lipid cells and blood-brain barrier, causing CNS manifestations in overdose. Beta blockers may cause sodium and potassium channel blockade, causing prolongation of QRS and QTC. Metabolic and cardiovascular pathways dependent on catecholamine are switched off due to a beta receptor blockade. Clinical manifestations, CNS manifestations may present as seizures, especially seen in lipophilic beta blocker overdose like propranolol. TVS effects, we see bradycardia, decreased myocardial contractility, hypotension, different degrees of AV block. Metabolic features, we can see hypoglycemia, bronchospasm, and lethargy, stupor, coma, seizures can also be seen in beta blocker overdose. Diagnosis and evaluation usually established on clinical grounds. Blood levels are available but do not correlate with severe toxicity. ECG, prolonged QRS and QTC intervals can be seen. Risk of seizures is high with QRS of more than 0.1 second. Hypoglycemia and hypokalemia are the most common findings that we see in electrolyte abnormalities. But coming to the treatment, again, initial stabilization ABC approach, gastric lavage, if within 1 hour of ingestion, activated charcoal may be used, but no role of multi-dose activated charcoal. Hypotension managed with fluids and vasopressors. Bradycardia, AV block managed with atropine, and if indicated, TPA can also be placed. Then glucagon also can be used in the treatment of beta blocker overdose. It effectively reverses the bradycardia and myocardial depression. It increases the CAMP and intracellular calcium influx, increasing the inotropic effect of the heart. Glucagon is administered as at a dose of 5 to 10 mg over 1 minute, then 1 to 10 mg per hour. Dilutions in saline or dextrose is recommended. Use of high dose insulin, euglycemia can be more superior than glucagon. However, there is still ongoing, still sufficient evidence or data is not available on this regard. The conclusion, take home message, diagnosis is usually on clinical grounds, especially history. We have to take the history of consumption of over-the-counter medications or empty strips. If needed, we can do a pill count. Then QRS of more than 0.1 second is associated with increased risk of seizures. Gastric lavage within 1 hour of ingestion. No role of multi-dose activated charcoal. Glucagon therapy effectively reverses bradycardia, myocardial depression, and hypotension. Use of HIE can be more effective than glucagon alone, however, needs more data. Now, calcium channel blockers of all substance subclasses reduce the pancreatic insulin secretion and induce end organ insulin resistance and causing hyperglycemia. Additionally, calcium channel blockers interfere with calcium stimulated mitochondrial action and glucose catabolism. This results in lactate production and ATP hydrolysis, contributing to acidosis. We are discussing about the calcium channel blockers also now. So initial symptoms may be as non-specific as dizziness, uh, fatigue, lightheadedness, and in severe toxicities may be rapidly decline in altered to mental status or to coma and a fatal shock. Profound hypoperfusion and end organ ischemia with severe overdose can cause clinical evidence of end organ failures like seizures, MI, ARDS, renal failure, bowel infarction and ischemia, and stroke. Diagnosis again similar to the beta blockers, ECG, sinus bradycardia, prolonged QTC, sinus rhythm, and reflex tachycardia may be seen in overdoses. Hyperglycemia in beta blocker, we see hypoglycemia, whereas in beta blocker, the metabolic parameters we can see hyperglycemia can be useful clinical marker for the severity of overdose. Metabolic acidosis, and again diagnosis is based on clinical grounds, that is robust history collection and physical examination will give you the diagnosis on the presentation itself. Now, treatment again ABC approach, gastric lavage can be given up to 8 hours of ingestion for sustained release preparations. Now, until now we have studied that only it is less than 1 hour, but for calcium channel blockers with the sustained release preparations, gastric lavage can be done even up to 8 hours of ingestion. Whole bowel irrigation may similarly be used. No role of multi-dose activated charcoal. Glucagon is administered as 5 to 10 mg over 1 minute, then 1 to 10 mg over 1 hour. Dilutions either in saline or dextrose. Calcium gluconate can also be preferred as an IV calcium agent. Several investigators have reported successfully reversal of refractory shock in calcium channel blocker toxicity with high intense euglycemic therapy by continuous infusion of insulin at a rate of 0.5 international units per kg per hour. However, larger trials are needed to confirm its safety and efficacy. So as I said in the beginning, there are no enough data or evidences supporting the or guidelines for drug overdoses. That is why we have very limited data or evidences for any treatments. To continue, take home message, non-specific symptoms, diagnosis is on clinical grounds. Hyperglycemia can be used as a clinical marker for severity of toxicity of calcium channel blockers. Sinus bradycardia, AV block, reflex tachycardia may be seen on ECG. Gastric lavage up to 8 hours of ingestion. Glucagon infusion, high intense euglycemic therapy more superior to glucagon therapy, however needs more data. Calcium gluconate infusion can be used. Now again I am coming to the question case dignity that I have presented in the beginning of my talk. So a 36-year-old male, known case of depression disorder on antidepressants, was brought to emergency with a history of a seizure episode 15 minutes ago. On arrival to ER, he was drowsy, opening eyes, and responding to deep painful stimuli, not localizing to pain. BP was around 80-50, heart rate of 145 beats per minute, and 12 lead ECG taken was suggestive of QRS of more than 0.12 seconds. So already we have discussed what will be our immediate approach, that is airway, breathing, and circulation. Because his sensorium is not appropriate, you would like to protect his airway first, then breathing, maintain the oxygenation, and also for hemodynamic circulation, we would secure 2 large bore IV cannulas, appropriate fluid resuscitation. If still unstable, then start on vasopressors, preferably norepinephrine. Now coming to diagnostic approach. If you see, first of all, we have to notice at the clinical features of what and the history and clinical features what we are seeing here. So in this, as per the case with Vinay, he is a depression disorder patient on antidepressants, and the prolonged on presentation he had seizures, and also 12 lead ECG taken is suggestive of prolonged QRS complex. They all are fitting in anticholinergic overdose. However, clinical features were not mentioned, that is dry mucous membranes and reduced GIT motility or constipation will also give you a little more idea about anticholinergic overdose. So here my provisional diagnosis will be based on the clinical features and the ECG. I would say that it could be a anticholinergic or a tricyclic antidepressant overdose. And how would you manage? Again, ABC approach, then decontamination, gastric lavage within 1 hour with activated charcoal, again within 1 hour of ingestion. And we can use, as we have seen, acidosis will worsen the free drug levels in the plasma of tricyclic antidepressant. So sodium bicarbonate infusion until your QRS gets normalized or your pH is more than 7.5 is one approach. That is how we will approach, diagnose and manage this patient. So what is my take home message? Always have a systematic stepwise approach towards the toxidromes. Initial assessment, robust initial assessment, clinical examination, and looking at the clinical features are very important. A, B, C, airway, breathing, circulation. Not necessary that you have to do it in a sequential order. You can do this A, B, C parallelly, also collecting the history and also having a clinical assessment of the patient. So robust clinical examination is necessary. Decontamination, have given you the gastric lavage indications where we have to do, where we cannot do. Like with unprotected airway, it is not recommended to do a gastric lavage, and also it is preferable if you do a gastric lavage within 1 hour. The only scenario where we can do gastric lavage even up to 8 hours of ingestion is calcium channel blockers with a sustained release preparations, where we have prolonged absorption, delayed drug absorption. And again, indications and contraindications of gastric lavage and activated charcoal, please remember these. And enhanced elimination, either by alkalinization, it can be forced diuresis, it can be sodium bicarbonate infusion, or if at all it is a dialyzable drug, we can also prefer for hemodialysis. That is how enhanced elimination is done. I would like to conclude my lecture and just give it back to hand over it back to Dr. Vinay.
Thank you, Prasad. That's an exhaustive talk on toxidrome. So to conclude it, like what we have learned. So what is a toxidromic approach? So basically, toxidromic approach is the patient who comes to ER or hospital. We don't know what kind of toxin he has taken. So you look at the symptoms and you try to identify what kind of toxin the patient might have taken. So it's a group of signs and symptoms which will help you coming to an diagnosis. So like there are different toxidromes. One is cholinergic toxidrome, anticholinergic toxidrome, sympathomimetic, hypnotic. There are various toxidromes. So that will be helpful for you to come to a diagnosis. Then comes the main three principles in management of these poisoning patients will be reduce absorption and enhance elimination and antidote. So how are you going to reduce the absorption? So gastric lavage and activated charcoal. So most of the poisons you will do gastric lavage and followed by charcoal absorption. So you should be aware of the indications and contraindications of these procedures. And how are you going to enhance the elimination of the toxin? So most of the time hemodialysis, you should be aware of the poisons which are hemodialysable. So when you do hemodialysis, the toxin removal will be enhanced. So in the same way, you need to be aware of the antidotes for that specific antidotes for that poison. So there are a big list of antidotes which Prasad already mentioned in the PowerPoint. So we need to be aware of these things. And apart from these things, always you should take care of any emergency patient, whether it is poisoning or any other patient. The airway, breathing, circulation is very important. And when the patient comes to ICU, maintaining the airway, breathing, circulation, along with that, maintaining avoidance of secondary infections, maintenance of feeding, DVT prophylaxis, all these things, supportive care will play a major role in any kind of patients. So hope you understand the toxidromic approach and how to manage different toxins. So if we discuss different toxins, it itself will be a very lengthy one. So he made it in a very short way, trying to discuss the most important things in each toxins. So if you have any doubts, you can put it in the chat box. We'll try to address them. Okay, so if there are no further questions, I think we'll stop the session at this point. So hope everyone understood this. So thank you very much for ICC for giving us this opportunity, and thank you everyone who has participated in this session. Thank you.
Thank you. Thank you, everyone.